learn something new. What we expect when we do the procedure, we may get something new. So we learn many new things today. So hope it will good learning for all. Thank you. Thank you all.
Thank you, Dr. Ghanshyam. Over to Dr. Satyan for introducing his great friend and colleague, Dr. Anup Thakur.
Absolutely. Thanks to IAP Delhi for making us chairpersons to interact with the lively audience on such an important topic. It's my pleasure to introduce Dr. Anup Thakur, who is a close friend and a very great, well-known academician in neonatology, who has taken the lung and critical ultrasound by leaps and bounds in India. So I'm sure he will do the best that can be done for such a important topic for all of you, and you will learn a lot. Happy learnings.
So before we hand over to Dr. Anup, few words from Dr. Alok Bhandari.
I also acknowledge presence of our past Secretary General of National Neonatology Forum, Dr. Lalan Bharti ji, who has always been at the forefront, and he has been there for bringing up NNF to these levels. Thank you, Lalan, for being here with us. And
thank you, sir. Thank you very much. I'm wishing all the participants a very happy learning.
So this is an effort where more than 200 people have already joined, and every second more and more people are joining. And I think we should not be coming in between science and the learning process of Sunday morning. So over to Anup, please carry on.
Thank you, sir. And yeah, a very hearty good morning to all of you. And thank you, IIP Delhi, for this great opportunity so that I can share whatever I have learned from my seniors like Dr. Pankaj Garg, who has not only been my teacher, but my mentor, my friend, and a very like a close guide for my entire life. Dr. Satyan again has been my senior, from whom actually I learned all the procedures. So it's really a proud moment for me to actually present what I learned from him. So he has to tell me what has gone wrong and what has gone right. And it's a great pleasure. Thank you, Dr. Lalan Bharti, sir. You're here and you have been really a professional guide to me. Dr. Alok Bhandari, sir, is really a great person, and it's good to have a call from him anytime. And he calls up for meeting, and I can go to him for any difficulty. And great to have all the other executives and office bearers of IAP. And good morning to all the delegates. It's really a pleasure to present to you this particular topic, neutral procedures. And in fact, it's something which is very close to my heart, being an intensivist. So if you are doing some level of intensive care, you should be knowing how to do neutral procedures in the correct fashion. The procedures which I'm to talk about are not really something which are rare or uncommon. I'm going to speak about the procedures which are very common and which every pediatrician should be knowing if he wants to deal with some kind of newborn coming to his NICU, whether it's a level 2 NICU. So he should be well versed with these procedures. Now, first of all is one should learn how to give surfactant via endotracheal tube. This is a very basic procedure, and you need this in premature babies whose lungs are deficient in surfactant. Second is how to do the intravenous cannulation in the correct fashion. So running an IV line is the first thing you need in babies to give IV fluids, to give medication. So this is something very basic, and you all should learn how to put IV line in the correct fashion. Although we must be doing this right from the time we will interns, but in NICUs, in intensive care units, you have to do it in a particular fashion. You have to take care of the sepsis and analgesia and everything. Third is lumbar puncture. So any baby in whom you suspect sepsis, you think about starting antibiotics. Even if it is a culture positive kind of scenario or culture negative kind of scenario, you need to do a lumbar puncture. So lumbar puncture is a very basic procedure in NICU which needs to be done. Then I'm going to talk about two central lines. So the PICC line, the peripherally inserted central line, which you need to start in certain babies, and the umbilical venous and umbilical arterial cannulation, which are actually the bread and butter for the neonatologist. The last, I'll talk about chest tube insertion. So chest tube insertion might be a skill which is a bit demanding, but at the same time, it is something which is life-saving. So that is why I've included this in the procedures today. I'm not going to talk about certain procedures which are not very commonly required. So that is ultrasound guided internal jugular venous cannulation or femoral venous cannulation, ventricular tap, exchange transfusion, peritoneal dialysis. Again, these are very highly skilled procedures, but might not be required that frequently, and this might not be a correct forum to talk about those. And I'm not going to talk about other methods of surfactant administration like Lisa and Salsa and all those. So we're going to stick to these six very basic neutral procedures today. Now, coming to just introduction about surfactant, we all know what is the role of surfactant today in neonatology. So surfactant, as we understand, is a surface active lipoprotein, and it is produced by type 2 cells in the lungs. So what happens in the alveoli? So in the alveoli during expiration, what happens? They tend to collapse because the surface tension in premature baby is high in the alveoli because of lack of surfactant. So what surfactant does? The surfactant decreases the surface tension in the alveoli so that they do not collapse during expiration, and lesser pressure is required to inflate them. So that's what is the function of surfactant. So without surfactant, the surface tension in the alveoli might be high as say 50 dynes per centimeter. And while you give surfactant, the surface tension tends to come down to 5 to 30 dynes per centimeter. So what it does to your lung mechanics is that if you presume that this is a pressure and volume curve, which is a lung hysteresis, so as you increase the pressure, as you go high on the pressure, what happens? The lung starts to open up. So as the pressure is increased, the volume also increases. So this is the loop during inspiration. And in expiration, what happens? Again, the lung starts to slowly deflate and it collapses. So with surfactant, what happens is that the opening pressure, the pressure required to open up the lung, it decreases. So you can give lesser pip to open up the lung. And then with certain increase in pressure, the same increase in pressure gives you much larger volume. So you're able to inflate the alveoli to a greater level. And there is also deflation stability. So when there is expiration, the alveoli do not collapse and they maintain a certain amount of functional rescue capacity. So that's what surfactant does in the lung, and it is something which we all should know how to administer in premature babies. Now, there are various guidelines of what cutoff we should be using to give surfactant in premature baby. So if you look at the guidelines followed by various country, in UK, the recommendation is that if the FiO2 is more than 30% in the first hour of life for babies who are on CPAP, then these infants should be given surfactant. The European guidelines is something which we have been following since last decade, and the European guidelines say that if on CPAP, the pressure requirement, the PEEP requirement or MAP requirement is more than 6 centimeter of water. And if the FiO2 is more than 30%, then surfactant should be administered. Okay. They also suggest using lung ultrasound as another scoring system to give surfactant. In Canada, the threshold is slightly higher. So they take a FiO2 cutoff of 50% to give surfactant, and they rely more on CPAP. Now, we in India have our own National Neurology Forum Clinical Practice Guideline 2021, which again takes the cutoff value of 6 centimeter of water on CPAP and an FiO2 of 30% to maintain saturations more than 91%. And the most recent one, 2023 guideline from US, had divided the indication of surfactant based on gestation and based on timing. They have taken certain other parameters into consideration, like clinical status, respiratory status, apart from the FiO2. More or less, if the FiO2 is more than 30% in first 2 hours of life, then surfactant needs to be given. And later, after 2 hours, they have taken an FiO2 cutoff of more than 40% in addition to other criteria. So cutting the long story short, most of these bodies, they recommend that surfactant needs to be given when the MAP requirement on CPAP is more than 6 centimeters of water and when the FiO2 requirement is more than 30%. So that becomes now the standard indication of surfactant in most units based on FiO2 and MAP. So all units who are spontaneously breathing should be given a trial of CPAP. And on CPAP, if the pressure requirement is more than 6 centimeters of water and the FiO2 is more than 30%, then you should consider giving surfactant to that particular unit. Now, let's look at what are the available surfactant and their composition in the market. So, I have named the products, but I don't have any conflict of interest from these companies. So, the first product is Surventa. It's manufactured by Abbott, and in 1 ml of the surfactant, it contains 25 milligram of phospholipid, and it also contains SPB and SPC protein. These proteins are important because they help in adsorption and spreading of surfactant in the alveoli. Then we have Curacov. Curacov in 1 ml contains 76 milligram of phospholipid. And the third one is NeoSurf, which is manufactured by Cipla, which in 1 ml contains 27 milligram of phospholipid. So, why you need to know how much is contained, how much phospholipid is contained in 1 ml is because there is a particular dose of surfactant. So, the dose of phospholipid which is recommended is 100 milligram per kg, except for Curacov, where the manufacturers they recommend a dose of 200 milligram per kg of phospholipids. So if you're giving Surventa, the dose becomes 4 ml per kg. For Curacov, it becomes 2.5 ml per kg. And for NeoSurf, it becomes 5 ml per kg. Now, these surfactant are either bovine or from porcine source. And Surventa and Curacov are extracts of bovine or porcine source. And NeoSurf is bovine lipid extract surfactant. Various formulations are available in India. For Surventa, you have 4 ml and 8 ml. For Curacov, you have 1.5 ml and 3 ml. And for NeoSurf, you have 3 ml and 5 ml. This was the cost when I last reviewed it. So Surventa is around 8,800 and 15,000 for these particular volumes. Curacov is slightly on the costlier side, so around 11,000, 12,000 to 20,000. And NeoSurf is slightly on the cheaper side, 5,000 to 8,000. So that is what we have today in the Indian market. When we talk about the type of surfactant, the source, the dose, and the available formulation and the cost. Now, if we talk about again how much dose to give, which surfactant is best. Now, whatever the evidence we have, if we just cut it short and based on the guidelines, the European guidelines is the first one which came with this kind of recommendation in 2019 first, and then in 2022, that initial dose of 200 milligram per kg of Porrectin alpha, I mean that is Curacov what is available in India, is better than 100 milligram per kg of the same molecule or 100 milligram per kg of Berectin, which is Surventa, what we get in India. So the current recommendation from Europe and from UK, both of them favor a dose of 200 milligram per kg of Porrectin alpha, and they suggest that this is better than Surventa 100 milligram per kg. Same has been also like engraved in the NNF guidelines that Curacov 200 milligram per kg might be better than Surventa, I mean Berectin, but the recommendation is weak, and the NNF has left it to the units to decide because the concern is the cost. And even in Canada also, it quotes the evidence but leaves it to clinicians. And in US, there's no clarification on which product to use. So whatever you're using, that is fine. Whether you're using any of these products is fine, but the evidence slightly is tilted in favor of 200 milligram per kg of Porrectin alpha. It might be better than 100 milligram per kg of other surfactant compositions are available. So now coming to after the indication, now we know that we are going to give surfactant to premature infants who have respiratory distress, who fail on CPAP, that is, they require a CPAP pressure of more than 6 centimeters of water and a fat of 30%. These infants need to be given surfactant. And we talked about the products which are available to give surfactant. Now, once you have decided that okay, these infant needs surfactant, there is certain procedure which you need to follow. First of all, of course, you need to discuss this with the parent and take a written informed consent that you why you need to give surfactant and what you're going to give actually, how you're going to give, what is the procedure, what is the expected cost, what is the anticipated benefits, what could be the risk and complications, and whether there are any alternatives. So, like you do for any other procedure, you have to explain everything, the risk, the benefit, alternative, everything. To give surfactant, you need at least two persons to be able to deliver surfactant. Now, we will be keeping usually surfactant in the fridge. So most manufacturers, they recommend a temperature of 2 to 8 degrees where surfactant needs to be stored. So you take it out of the fridge, the surfactant, and you have to keep it in room temperature. So you have to keep around 20 minutes in room temperature, the surfactant which you have taken out from the fridge. If you want to warm it more rapidly, you can warm it with your palms. Now, next thing is that you have to perform hand hygiene in a proper manner, and you have to take all the universal precautions, the aseptic precautions. So you wear a proper cap, mask, gloves, gown. So it has to be done totally. Total asepsis should be followed. Now your supplies should be ready. So you should have a sterile tray, surgical blade, 11 and 13, a 10 ml syringe, and a wide bore needle at least 20 gauge. So because you need to withdraw surfactant and it's a very thick kind of solution. So you need a wide bore needle. Okay. Now, you have to keep the endotracheal tube of appropriate size ready, depending on the gestation and the weight. So in this slide, I'm just showing you how to deliver surfactant via a feeding tube. So you have to take a feeding tube, a 5 French or 6 French feeding tube, depending on what kind of endotracheal tube you're having. So for a 2.53 size, carry a 5 French feeding tube. And for a larger tube, you need to carry a 6 French feeding tube and see whether that feeding tube could be easily negotiated through the endotracheal tube or not. And the length of the feeding tube needs to be kept in such which should be the length of the endotracheal tube to be inserted plus the length of the adapter plus 1 centimeter. So let me explain this further. For example, you decide to intubate the patient, then at what length should you fix the endotracheal tube? The standard recommendation currently by the NRP is to measure the nasopharyngeal length. So length from the midpoint of the septum to the tragus, and then you add one into it. So for example, the length is 6 centimeter, then you add one to it, it becomes 1 centimeter. So that is the depth of the endotracheal tube to be inserted. Now, usually the length of the adapter is around 2 centimeters. So you can add 2 to this length. And what we are going to, uh, how we are going to have the feeding tube is that it should just come beyond the endotracheal tube. So you can add 1 more centimeter to it. Okay. So that is how we calculate the length of the feeding tube. Until plus 1 plus add 2 centimeter to it, and it should just protrude beyond the endotracheal tube. Other way around is that you pass the feeding tube uh, through the endotracheal tube and see at what length it protrudes just beyond the endotracheal tube. At this length, you can cut the feeding tube to deliver surfactant. Okay, so that is how we calculate the length of the feeding tube. So once you have the endotracheal tube, the feeding tube is cut into appropriate length. Then you intubate your baby as per the standard technique. Now, you on intubation, fix the endotracheal tube at NTL plus 1 length. This should be your insertion length. You confirm that the endotracheal tube is in place by looking at signs of successful intubation. Look at the air entry that it's equal on both the chest. If the tube is deep, you will find the breath sounds to be more clearer on the right side. So that should not be the case. Then once you've intubated the baby, you create a sterile field. So look at, you have to create a sterile field all around the baby. So, or you can use an ice sheet as well. The surfactant vial, once it is open, it needs to be clean with a spirit swab. So with a spirit swab or with an alcohol swab, you clean this. There's a rubber here, so you clean this rubber of the vial with a spirit swab, and then you take a 10 ml syringe with the white bore needle, which we discussed, 20 gauze, to draw out surfactant from this particular vial. So once you have loaded the syringe with surfactant, what you need to do, you need to disconnect the patient from, disconnect the ventilator from the endotracheal tube, and you connect the loaded syringe along with the feeding tube into the endotracheal tube. Now you deliver surfactant in 3 to 4 liquids. So each liquid may take just a few seconds depending on the baby's tolerance. So if baby is tolerating, baby is not desaturating, you deliver in 3 to 4 liquids. After each liquid, you can give some ventilated breaths or positive pressure breaths in between. Now connect the baby back to the ventilator and avoid doing a suction at least for 1 hour unless it is pertinent or there are signs of airway obstruction, baby is desaturating, you're not able to manage by increasing the settings. Then, as per the baby's condition, you may decide to extubate the baby to CPAP if you decide to ensure that that could be taken. Now, this is the way to deliver surfactant through a feeding tube. Now, we also have available endotracheal tubes which have a side port. So we have a side port. So you don't need to disconnect the ventilator from the endotracheal tube, and you can deliver surfactant from the side port. Okay, so that is much easier and convenient. And the rest of the process is all same, whether you talk about the consent part, about the sepsis, sterility, all remains the same. So this is how a surfactant is delivered through endotracheal tube. Now, while you're delivering surfactant, there are certain important things which you need to also take into account. Now, first is the monitoring. So when you're giving surfactant, you need to monitor what are the baby's vitals, baby's saturations, heart rate. Everything needs to be monitored because it can lead sometime to transient bradycardia. It can lead to desaturations and hypoxia. So that needs to be taken care of. You may need to increase the FiO2 or increase the pressure or give some manual breaths when you are giving surfactant. So monitoring is very important. And make sure during the process, your endotracheal tube is in place, nothing has been dislodged. So these things needs to be taken into account. Next is about the ventilatory settings. So when you give surfactant, your ventilatory settings should come down if the child is responding to surfactant. So if you're not planning to extubate the baby at that moment, then make sure you cut down your pressures. Look at what is the lung compliance. Look at the tidal volume which is being delivered. And if you're on pressure mode of ventilation, cut down the pressure. If you're on volume guarantee mode, then the ventilator will automatically cut down the pressure by itself and will start to wean the patient. Next is that once you have given surfactant, it has to be documented in the file very clearly that what was discussed with the parents, what surfactant was delivered, what was the method by which surfactant was delivered, who delivered the surfactant, who assisted while delivery of the surfactant, what was the endotracheal tube size used, what was the product which was used, how much ml, what was the volume which was given. Everything needs to be documented. And was there any difficulty or was there any complications during delivery of surfactant? So what we do, we also put a sticker in the file because that becomes sometimes important for insurance companies in India, that when the sticker is in place, and there is also now a kind of recommendation by some of the authorities that you put the sticker by the NABH if you're putting a central line of your if you are using any kind of product in the patient which might be costly, right, then you need to put the stickers. Then complications of surfactant therapy, as I told you, could be most commonly bradycardia, could be airway obstruction because of the volume of surfactant, desaturations. These are the most common ones which we usually see. If the ventilator settings are not cut down rapidly, if you continue to ventilate with high pressure, there could be complication of pneumothorax. Some of the synthetic surfactants, the first generation ones, have been associated with pulmonary hemorrhage, and there are other lot of complications which have been referred to in the product manuals, but we normally don't see those kind of complications. Other techniques of surfactant administration are Vileza or mist. So here you use a kind of very thin tube to deliver surfactant without intubating the patient. And then you have laryngeal mask airway to deliver the surfactant. And there are other strategies which I'm not going to talk about today. So surfactant is something which is actually which I wanted to learn when I first joined Gangaram Hospital, because during our MD days there was the institute where I got my MD didn't have a ventilator till I actually was in the third year. So that was actually my first love to give surfactant. But when we all first become doctors, we learn the first thing is to start an IV line. And that is actually something which we are very obsessed about doing. And we also declare to our neighbors that, okay, we have become a doctor, we can run an IV line, we can give an injection and so on. So peripheral IV cannulation is something which I really want to impress upon this honorable delegates, that we all need to learn and should be doing it with a correct fashion. In fact, if you ask me, of all the procedures, this is something which I really struggle to manage the asepsis and do it in a correct fashion, while I'm able to do the most complicated processes quite easily, managing all the steps. Because when we think about peripheral IV cannulation, we think, okay, it's something which is very minor thing to do. I can do it just in a one go. And how we perform it, that's become very important in NICUs. This is the whole list of supplies which you need to have: sterile gloves, sterile syringe with normal saline, gauze. Chlorhexidine solution is something which we use for the skin preparation. You should have some adhesive or tegaderm. And the cardinal steps while you put the IV cannulations, one is to manage analgesia. This is something which we often forget as in the NICU, where we're not able to hear, we're not able to see that the baby is in pain. So analgesia is something which is pertinent when you put an IV cannulation or do any kind of intervention. For peripheral IV cannulation, you can use analgesia like sucrose, or you can maybe just divert the baby, do some tackling. That should be okay. So sucrose is something which can be used. It's available now. Next is you have to perform the hand hygiene in the correct fashion, and you have to give the same importance to hand hygiene while putting a peripheral IV cannulation that you give when you put a central line. The third thing is to know how to use gloves and wear gloves in a proper fashion. So it not just you have to just wear a glove, it has to be done in a proper fashion. Fourth step, which most of us tend to forget, is when you prepare the area with chlorhexidine, our tendency or reaction is to just mop the area and put the cannula. So that should not happen. So you allow the prepared area to dry. So wait for some time, at least 30 seconds you have to wait before you prick the baby once you have prepared the skin. Okay. And once you have prepared the skin, try not to touch it again. So that's what we call ANTT, aseptic non-touch technique. This should be your intention. Now, these are the two cannulas which are most commonly used in most of the NICUs. So this is a 24 gauge cannula, and this is a 22 gauge cannula. We also have a 26 gauge cannula, which is a purple cannula used in extremely low birth weight or babies who are very small. So with this kind of preparation, you need to go in to put a peripheral IV cannula and keep these steps. These are the major ones which you need to keep in your mind, that have you administered some kind of analgesia to the baby? So it could be sucrose, or in some babies, you can also apply EMLA gel, avoid in premature infants. That has to be applied at least 30 to 60 minutes before. Or you can apply lidocaine 4% gel. That can also be done. Then you take care of the hand hygiene part, the glove use, prepare the area, allow it to dry for 30 seconds, and just make sure you don't touch it as much as possible, which is called the aseptic non-touch technique. Now, this is how you're supposed to wear gloves in a proper fashion. So once you insert one hand, you have the other glove, then you touch the outer surface of the other glove with this, and you wear it in this particular fashion. So you have to make sure that you don't touch the glove from outside when you wear this one, because then this part will become unsterile. And when you have wore one glove, then you hold this in this particular fashion, and this is how it needs to be worn. Now, let's go through this video, and it will take us through the steps of peripheral IV cannulation. So first of all, you need to identify a good vein. So before really starting to put in the cannula, see where you have a good vein, whether it's the brachial vein, or you want to put it on the dorsum of the hand, you want to put it on the saphenous vein. Next is you can use a trolley and clean the trolley, clean the surface, the trolley or the table with chlorhexidine. And you can start collecting your supplies like your syringe and everything, or the cannula, your gauze, chlorhexidine, gloves, everything. And you ask your nurse or sister if they can bring in a sterile tray that is ideal to have to begin with. Okay. So this is the process of performing hand hygiene as you start to think about putting an IV cannula. So you follow all the 6 steps of washing your hands from palm to palm, back of hand, knuckles, thumbs, fingertips. So all this needs to be taken care of, and then you need to wash your hands and keep your hands in a way that you don't touch anything else after you have washed your hands. So this is one of our residents trying to put in an IV cannula. He has performed the hand hygiene. And after that, you see the sister has opened the first layer of the tray. He opens up the second layer of the tray. The tray is open, and the assistant starts to put or give the supplies one by one. So first he puts a sterile sheet inside the tray, and then he puts other supplies like the gloves, and then he will need to put in the IV cannula. So see the process how he's trying to wear the gloves. So this was what I showed you in the picture. Then he takes gauze, and he takes the eye sheet which he needs to use, the IV cannula which he's supposed to put in the baby, and he will have another pair of gloves because he will be using 2 pair of gloves. Then he starts to prepare the area and where he's going to put a IV cannula. So you need to prepare it with chlorhexidine, what is recommended currently by CDC. And you can use 0.5% chlorhexidine with 70-80% of alcohol. You place the eye sheet properly. Once the area is prepared, you see he's allowing it to dry, and he has changed the gloves again. And then he inserts the IV cannula into the vein at slight angle. He'll withdraw the needle to check. Yeah, so the needle is withdrawn to see for free flow of blood, and then the cannula is further advanced. And then after advancing the cannula, he will flush it with normal saline, and he will then close the hub. Okay. And you need to fix the cannula with a semi-transparent dressing so that you can see the tip always. Now, applying splint is optional, so it depends where you put the cannula. You want to apply a splint or not. Now, to discard all the consumables which you have used in proper like bins or dustbin, perform hand hygiene again and document in the file that you have put a IV cannula, what is the site, where have you put the cannula, what is the date and time. Okay. So these are the steps of putting a IV cannula. So make sure that you take part of the hand hygiene part is extremely important. Gloves has to be worn in proper fashion. The area has to be prepared. You allow the area to dry for at least 30 seconds before you think about picking the area. And once you prick the vein, you withdraw the cannula slightly, see that there is a free flow of blood, and then insert rest of the cannula. And you flush it with normal saline, make sure there's no swelling, and you fix it properly with a semi-transparent dressing. So this is how we put IV cannula in our unit. And that was just a video demonstration for that. The third procedure again is something which we perform a lot in the NICUs, which is lumbar puncture. And the indications are basically whenever you suspect that there could be meningitis. So in all cases of sepsis, wherever you start antibiotics, except for the ones which are delivered with some risk factor, barring those, in all cases, whenever you suspect sepsis, you are supposed to perform a lumbar puncture. The other indication of performing a lumbar puncture could be when there is ventriculomegaly. So you need to withdraw CSF because you want to release some pressure on the brain. So there you can perform lumbar puncture if the ventricle size are enlarging beyond 97 centile. That is what we followed on the Levine index. The contraindications for lumbar puncture are very few. So if the patient is very unstable and you think will not tolerate the procedure, it's having hypotension, is even on ventilator, not maintaining saturations, you can avoid lumbar puncture. Make sure he's not bleeding actively. So in those cases, lumbar puncture should be avoided. The local area should be free of infection. There should be no deformities of the spine. So these are some kind of contraindications where you do not perform a lumbar puncture. Now, what is important to understand that which site you're going to insert the needle in the spine. So what is recommended in newborn is you insert the needle between L4 and L5 or between L3 and L4 because the spinal cord, right, it ends say around L1 in adults, but in newborn it may extend beyond L2 and in premature baby even up to L3. So the site where you are supposed to insert the needle is between L4 and L5. And if you're not getting the CSF here, then you may go one space up between L3 and L4. Don't go above that. So that should be avoided because that can cause injury to the nerve fibers or the spinal cord. Now, again, the basic things needs to be followed. You need to have a complete supply, a tray ready, which has all these consumables like the surgical gloves, the gown, cap, mask, drapes, disposable containers, at least four in number. Ideal thing would be to have an LP needle with a stylet. If this is not available, you can use needle of 23, 24, 26 gauge to do a lumbar puncture. Commonly, we use the 23 or 24 gauge needle. In babies who are very small, premature, 750 gram or less, we use sometimes the 26 gauge needle. Make sure you prepare the site well. You should have a proper dressing as well after you have performed the lumbar puncture. Now, let's go to the steps and what are the cardinal points which are important when you do a lumbar puncture. Again, the informed consent is the first thing. Once you have planned the lumbar puncture, you need to talk to the parent. You need to inform them that, okay, this baby deserves a lumbar puncture. Then you need to explain to them why you're doing the lumbar puncture, how you're going to perform the lumbar puncture, and what you're going to do with the fluid, and what are the indications for that particular patient. And you also need to inform the patient about the expected complication, what can happen. Okay. Now, again, here also you need to take care of the analgesic part, which we often tend to ignore. But this is something which is recommended. You can again use the similar things like you use for IV cannulation. So you can give oral sucrose to the baby, 24% solution, or you can apply some kind of anesthetic gel on the lumbar puncture site. So it could be either an EMLA solution, which is lidocaine plus prilocaine, or it could be 4% lidocaine gel, which could be applied at the particular site. Now you're going to enter a very sterile space, I mean, in the baby, which is, of course, you're going to withdraw the spinal fluid. So all asepsis need to be taken care of. So you perform the hand hygiene in a proper fashion. You make sure you wear your mask, your cap, and gloves and gown in a similar fashion. So everything, all the precautions which you take when doing any kind of invasive procedure that needs to be taken during lumbar puncture. So these things I'm stressing again and again, the informed consent part, the analgesia, asepsis, glove use, because these are the things where bleach should not be there whenever you're performing any procedure. Then positioning becomes important. So when you position the babies, what you do, you tend to flex the thighs and you flex the shoulders slightly so that you can bend down and you can produce a bend here. And the gap in between the spine, the vertebrae, they increase. So that's the whole idea. Now, in newborn, you take a precaution that you don't need to flex the neck too much. If you flex the neck too much, then it could cause obstructive apnea. So this positioning is important because you need to have a space where you're going to insert your needle. And when you position the patient like this, baby like this, in a lateral position, slightly flexing the hip and the shoulder here, then the space between the vertebrae they increases, and it will be easier for you to introduce the needle. Then preparation of the area needs to be done, and that you can prepare with again with 0.5% chlorhexidine with 70% alcohol. Prepare it from center to periphery. Again, allow it to dry. That's very important. Next, you drape the area, or you can use an ice sheet like this to make sure you have a sterile feel all around this particular area as well. And that is also important so that you can keep your supplies sometime here. Then identify the site of puncture. So as I told you, the puncture site is ideally between L4 and L5. So you palpate the anterior superior iliac crest, and the corresponding vertebra here is L4. So you can go one space below between L4 and L5. If you're not able to withdraw CSF from there, if it's a dry tap, you can go one space up. That's it. So this is how you identify L4 by palpating the anterior superior iliac spine. Now, when you insert the needle, you go very gradually and slowly. Don't insert it in one go because you will have a traumatic tap. And the insertion should be towards the umbilicus, that you direct it towards the umbilicus. Okay. And then CSF is collected in all the sterile containers. And you withdraw the needle, apply pressure at the puncture site to avoid any kind of leak. And you reposition the baby and you dress the site with some kind of occlusal dressing like pedotecarum. Discard the waste in the proper bins. And again, you document the entire procedure. So how you have done it, what has been done, who has done it, whether there any complication that has to be documented. Okay. So these are the cardinal points which are to be kept in mind when you're performing a lumbar puncture in any newborn baby. Now, these are the lumbar puncture needles which you can purchase online, and these are available for around 250 rupees. And what currently we are not using these needles, we are using the common 24 gauge needles to do lumbar puncture. Some precautions again is to not to flex the neck and insert gradually when you insert the needle. And needle doesn't have to go very deep because the spinal cord depth in neonates is just around 1 to 2 centimeter. So from 0.9 to 1.7 centimeter. So that is the depth. So between 1 to 2 centimeter, in most cases, you will be getting the CSF fluid. So this is how lumbar puncture is being performed. I have bypassed some of the steps, but doesn't mean those are important. So the area is prepared, and then she has changed her gloves. Again, she has put her eye sheet there. And there's another assistant who is trying to position the baby by flexing the hips. She's palpating, see, with one finger here, she's palpating the anterior superior iliac spine. Other finger, she's trying to find out the space between L4 and L5. And then she's trying to insert the needle gradually. She failed once. And see, she's doing gradually, she inserted. And just with 1 to 2 centimeter of insertion, see, she's getting a clear fluid, which is the CSF here. Okay. You collect the fluid in your sterile container, and then you hold the area where you have pricked after withdrawing the needle with a sterile gauze. And after holding it, pressing it for some time, you press an occlusive dressing on that particular area and discard all your consumables in correct greens. and you document the entire process. So this is important to fill the gap while your other hand is at the anterior superior iliac spine and iliac crest, and then insert the needle in a very gradual fashion. Don't go deep. If you go deep, you're going to hit the bone, you're going to hit the vessels there. It will not serve the purpose. So go gradually. The position is very critical. You have to make sure that space is provided sufficient so that you can go inside the intervertebral space. At the same time, don't flex the baby's neck too much because that is going to cause obstruction to the airways that can lead to apnea or desaturation. Okay, so far we have covered right now as surfactant administration, IV cannulation, and lumbar puncture. So we'll take our discussion to slightly higher level. So the third is PICC line insertion, peripherally inserted central catheters. Now we need these kind of catheters which are inserted peripherally if you need an IV line for a longer time. So you need a prolonged IV access. You need to administer hyperosmolar fluids, which have osmolality of more than 900 milliosmoles. So in those cases, you need a peripheral inserted central catheters. And these is not a very complex process. If you are able to insert a cannula, if you know how to insert a cannula, you can also insert peripherally inserted central catheters. The contraindications are relative. If you find any local site of infection on that particular portion or there are irregularities in the chest wall, then you avoid the upper limb. And if the patient is bleeding, then you avoid inserting a peripherally inserted central catheters. Now, currently, what we have in our country is the various kind of peripherally inserted central catheter line. Most common ones which are used in the NICU is the Primicac. This has a stylet, and this is really a wonderful technology which the companies have come up with. It is the gauze is only 28 gauze. That means it can go through even a 24 gauze or 26 gauze cannula also, and it's just one French. The length is 20 centimeter. It has a breakaway needle along with it, and the maximum fluid rate is around 0.7 ml per minute. So that comes to roughly around 30-40 ml per hour. That is what you can deliver. So this is one which is the most commonly available now. And then there are other lines like the epicutaneous lines, the Nutri line with stylet, and there's some Nutri line with double lumen also. These are little larger lines like 2 French, 3 French lines, and these are also longer. And for this, the introducer needs to be a bit bigger, so around 20 gauze. So you need either a pink cannula to insert these. The advantage is that they have a much higher fluid rate, so it may go up to 5 ml per minute, so roughly 120 ml or almost 300 ml per hour is what it can go up to. So in nursery, what we do is right now we have the Primicac, which is very easy to insert, which is very thin. The only problem is the length is small. So if you're going through the lower limb, it might not reach the position where you want your PICC lines to be. Now, what are the steps of insertion of a PICC line? So first of all, again, you have to make sure of the informed consent part. You talk to the parents, you take the informed consent and all those. Make sure you take care of the asepsis. Make sure you take care of the analgesia. So these things have to be taken care of. You select the vein where you want to insert a PICC line. So these veins could be in the upper limbs or it could be in the lower limbs. Now, compared to upper limbs are the one which are favored compared to sides, right or left. The right sides one are favored because they are more straighter. Now, it could be anyway. It could be the basilic vein, it could be the medial cubic vein, it could be somewhere below the great saphenous vein or behind the small saphenous vein. Any of these veins could be used to insert a PICC line. So gather all your supplies and you position the infant in a proper fashion wherever you want to insert the PICC line. Now, 2 persons should be there whenever a PICC line is inserted. Take care of the analgesia. In the same fashion, you can give sucrose if you want to. Now, to take some measurements when you are inserting a PICC line. So if you're inserting a PICC line in the upper limb, so how long you are going to insert? What should be the length of insertion? For that, you take a measurement from the point of entry, so up to roughly the second rib. That is what we take in the midline. So just below the sternal notch, you can palpate and you know where the second rib joins the sternum. So that is what, this is a slight elevation here. So this is the expected length if you're going to put a PICC line in the upper limb. For the lower limb, you measure it from the point of entry up to the xiphoid. Okay, up to the xiphoid, you need to measure the length, and this is what is the length of insertion. So these PICC lines, they have a sterile tape into it, so you can use that tape in that particular set. Now, again, during insertion, you have to take care of the insertion bundles. So it is again done in a sterile technique. You have to wear your cap, your mask in a proper fashion. You perform hand hygiene. You wear your gown, and you have to maintain sterility while you perform the procedure. You have to prepare the process, prepare the site with chlorhexidine, again 0.5% or 2% with 70% alcohol, and you wait for at least 2 minutes for the area to dry. So in a peripheral IV cannula, we were waiting for 30 seconds. In central line, what is recommended by CDC is to wait for 2 minutes to allow it to dry. And during the process, you need to maintain the vitals, and you need to fix it once you've inserted it, and the documentation needs to be proper. So I'll show you a video of PICC line insertion, and that will take you through the steps, okay? And they'll make it easier to understand. Okay, so what has been done here, there are two people you see, and both of them are properly gowned, they are gloved, they have taken care of all the sterility. They have prepared the area, and then you see nothing is exposed, only the area where the PICC line is being inserted is exposed. Once they prepared the area, they change the gloves again, the person who is introducing the line, and then the introducer is introduced into the vein. And once the introducer has been introduced and there's a free flow of blood, then he takes a iris forceps here. It's a non-toothed forceps, and he inserts the line gradually, very slowly. That's what he's doing. You see here, look, this free flow of blood. He takes an iris forceps, which is plain, and he goes through the needle. So if he's finding some resistance, he's asked his assistant to straighten up the limb, and gradually, just in each stroke, just 1 centimeter, 0.5 to 1 centimeter, he's inserting the line through the particular needle. Once he has reached his expected length, he withdraws the needle back. It's totally out now. Needle is out. You can see the tip with the line. He breaks that, and he asks the assistant to hold it stably, and he will now peel off the needle. Needle is out. The line is there. And this line, they contain a stylet into it. So he's trying to stabilize it with one hand. And now he needs to take out the guide wire, which is in the line. So what he does, he is taking out the guide wire, okay, very gradually. So it may take around 30 seconds to 1 minute to take out the guide wire very gradually from the line. And look at the guide wire. It is very thin. It is as thin as your hair, maybe. The guide wire is taken out very slowly. So this is the guide wire. It's very thin. So this PICC lines now, epic witness lines have guide wire to make them stiff. It's easier to insert. And then with the syringe, again, what he does, he will not push now. He will look for backflow. So he will withdraw to see for the backflow. So he wants to see the backflow. So he already sees there is blood in the hub, which is coming. So he's satisfied that the line is inside the vein. And then you need to fix it. You hold the insertion site for some time with a sterile gauze, because otherwise it will keep on bleeding and the dressing is going to become dirty. So you hold the prick site with a sterile gauze for at least like 1-2 minutes so that there's no bleeding later on. and you dress it properly with semi-occlusive or transparent kind of dressing should be what should be done for PICC lines. Okay. Now, once you have done it, you need to fix it. So what are the important things is I told you about the site of puncture. So you prefer the upper limb compared to lower limb, prefer the right compared to the left side. And you need to make sure that you hold the puncture site for some time to avoid any kind of bleeding. Speed of advancing the catheter is very important. You cannot advance it very fast. So you go it slowly, say just 0.5 to 1 centimeter per stroke through your forceps. If you have difficulty in advancing the catheter, you may need to manipulate the limb, position the baby, stretch the limb. You may need to palpate the catheter sometime up to where it has reached. We sometimes do massage of that area, or you flush that with normal saline to advance it bit by bit. So that should be tried. If this is not happening, then you need to try again and take it out. While dressing, one tip is that you can, this side where you have pricked, you need to hold that with gauze. Sometimes we cut the gauze into a very small piece, dip it in adrenaline and hold the side so that there is no bleeding. Now, then you need to confirm the site with an X-ray, and that is what is standard. And doing X-ray, you need to make sure that if you put in the upper limb, the arm should be abducted to when you take the X-ray. Otherwise, the line will not be in the optimal place. It might move. On if you are doing in the lower limb, the hip needs to be extended. So this is important when you perform an X-ray. Now, these are the various ways to confirm the PICC line. So if you are putting a PICC line in the upper limb or lower limb, so an upper limb PICC line should be at the junction of right atrium and the superior vena cava. The lower limb PICC line should be at the junction of IVC and the right atrium. So if it is short in the IVC also, it is still acceptable, the lower limb PICC line. If you want to look on X-ray, then for the upper limb PICC line, the tip should be located in the SVC, and roughly that is what is indicated now is 1.3 vertebral units below the carina. So when we were fellows, we were told it should be just outside the pericardial reflection, but it's very difficult to recognize where is the pericardium. So the current recommendation is that it should be below the carina, roughly 1.1 to 1.5 vertebral units. One vertebral unit is one vertebra and one intervertebral disc. So here, if you presume that the carina is somewhere here, so this one vertebra plus one disc is 1 unit, other vertebra plus disc is 2 units. So this is how it needs to be placed in the optimal position on the X-rays for the upper limb PICC line. For again, you can, if you have ultrasound available, then you can quickly do an ultrasound and see how the lines are. So this is how a PICC line will look in an ultrasound. This is SVC, and this is the right atrium. And you see the PICC line is exactly at the SVC and the right atrium junction. So ultrasound gives you the real-time view. You can see the tip very clearly. You can flush it with normal saline to confirm again. So that's the beauty of ultrasound. And for the lower line, it should be between the IVC and the RA. So this is the right atrium when you look at the IVC. This is the IVC. And see, here is the line between the IVC and the RA. So this is the RA, this is the IVC here, and this is the hepatic vein here. And here the line is seen very clearly. Okay? So we also did an ultrasound and X-ray agreement study, and Dr. Pankaj was in fact a part of this study. We published this in Indian Pediatrics. So there's good agreement between ultrasound and X-ray when you want to look at the tip of the PICC line. And so if your unit is good in ultrasound, you can see the tips very easily. Now, what the important part that we don't really take into account is documentation, and make sure all these points are covered when you document insertion of PICC line, because from insurance point of view, from medical legal point of view, everything is very important, the consent, because it can cause complications. There can be bleeding, there can be infection. PICC lines are notorious to migrate. They can migrate anywhere. They can go anywhere. They can become short. They can go into the heart. They can cause complications like arrhythmia, pericardial effusion, cardiac tamponade, all those. So make sure everything is documented in a proper fashion. And these are the points which you need to consider during documentation. What was the discussion? Who put the PICC line? What was the distance? Which catheter was put? What was the batch number? So again, you can place the sticker site of insertion, antisepsis used, what was the length of catheter, and whether you could find blood aspiration or not, what was the position on X-ray, who approved after seeing the line on the X-ray. So it should be another person who should be approving the line on the X-ray and any manipulation if it was done. You need to take care of this bundles. So daily you need to assess whether the line is required or not. If not, take it off. You inspect the site at every site. You have to scrub the hub. The hub, whenever you approach the PIC line, there should be a dedicated line for parenteral nutrition. You change the dressing only if it is visibly soiled, and you have to take care of the education and training part. So these are the various complications, some of which I have already discussed. And the next important procedure is umbilical venous and umbilical artery cannulation. So I'll spend maybe 5 to 10 minutes here. Now, umbilical vein, if you see the umbilical vein, it proceeds to enter the portovenous complex. So this is the portovenous complex. And the natural tendency of the umbilical vein is, or the umbilical line will be to turn towards the portovenous complex, towards the right side. This is the natural tendency, the natural path. We want our umbilical line to proceed from the portal venous complex to negotiate into the ductus venosus, this connection here, and then reach the IVC-RA junction. This is what we want. So many of the umbilical lines, more than 50%, they are malpositioned because they tend to follow the natural route. Okay, so this is the umbilical venous cause. For umbilical arteries, there are two umbilical arteries, and these umbilical arteries, they dip down towards the pelvis, and they join the internal iliac artery. Okay? And from the internal iliac artery, they proceed upwards to the common iliac artery and then to the descending aorta. Now, there are two sites where you want your umbilical arterial line to be placed. So one is the high placement, where you want the umbilical arterial line to be placed between T6 to T9. The reason is that here there are no other branches of the descending aorta, which is critical. Or you can have it somewhere between L3, L4, and this place, L3, L4, L5. This is the low placement. So most of us, we prefer the high placement of the umbilical artery line. You don't want it to be in the areas where there are critical branches. So if you see between from T10 to almost L1, L2, there are critical branches like the celiac artery, the mesenteric artery, the renal artery. So these are important, and you don't want your tip to be in these areas. So the contraindications for putting umbilical lines would be when, of course, there is some local infection, or when there is vascular compromise of the lower limbs, you don't put an arterial line. If there is bleeding tendencies, or if the abdominal wall defects like omphalocele, or if there is already a necrotizing enterocolitis, peritonitis, you should be avoiding putting an umbilical artery line. Now, before putting a umbilical artery or a venous line, you need to measure the distance from the acromion of the shoulder till the umbilicus. So this is called shoulder umbilical distance. Okay? So depending on the distance is what will be your length of insertion. So for example, your shoulder to umbilicus length in the baby you found to be around, say, 12.5 centimeter. So the distance through which you need to put your umbilical artery, where it should be in the high position, is around, say, 16 centimeters. Okay. So this is how we measure. Now, again, for example, you measure the shoulder umbilical length to be 15 centimeter. So the distance to which you are supposed to insert your umbilical artery catheter is around 18 centimeters. So this is how uh, these graphs, these charts are used, and this is how you place the umbilical artery line. Okay? There are various formulas again, some of them can be used, like the UC insertion is thrice into birth weight plus 9, and so on. Now, for the umbilical venous insertion, again, what you do, you measure the shoulder to umbilical distance, and you want the umbilical venous lines to be above the diaphragm, but not in the left atrium. So it should be somewhere here. So if the umbilical to shoulder distance is, say, 13.5 centimeter, then you need to insert the UVC till 9 centimeters. So these are Dunn's formula, these are Dunn charts which are available. This can be used. There are various other formulas which people can like put in the units. For the UVC, it is say half of the umbilical arterial length plus 1. So these are some formulas which I use. This can be used if you want to. Otherwise, these charts are very convenient to understand and use. Now, the procedure is again same. Take care of the informed consent, asepsis, and have all your supplies ready whenever you plan to put a umbilical arterial or a venous line. For babies who are less than 1.2 kilos, you can use 3.5 French of umbilical artery catheter. For more than 1.2 kgs, you can use the 5 or 5.5 French. UVC, since the umbilical vein is usually a bit larger, you tend to put larger catheter, 5.5, 6.5, so on in the umbilical vein. Now, one equipment which is very crucial is to have the iris forceps or umbilical dilators when you're putting an umbilical venous or arterial line. So same way as we talked in the earlier procedures, your supplies should be ready. So you should have a list of all the supplies. And how you do is you you prepare the site, you scrub the umbilicus and the entire site, and you make a sterile field around, and you place the umbilical tie, and you hold below the clamp with another faucet, cut the umbilicus in a way that it is very straight, not curved. You identify the three vessels. So the vein is usually larger and is thin walled. The arteries are thick walled, they are smaller. So you can identify the vessels. Now, first we put the artery line usually because they are the more difficult ones to put. So we start dilating the arteries, the one of the umbilical arteries, you start dilating. So put one limb of the iris forceps in the artery very carefully and in the lumen, and you start dilating it. Okay, and this is the most crucial step when you put umbilical artery line. Otherwise, you're going to fail or you may produce a false track. Once you've dilated it considerably, you can take the two limbs together and further dilate the umbilical arteries. Let the two limbs be inside the umbilical artery for a few seconds, and then you allow the forceps to gradually open up to further dilate it. So once you have dilated the umbilical artery carefully, then you can put the line, take the forceps and insert the line here again. For umbilical venous line, it's not difficult. It's a wide lumen, so just clear it with if there are any kind of clots, and you can insert the umbilical venous cannula easily. So once you put it, you confirm it. So this is what your umbilical venous cannula should be at the level of the diaphragm, around T8. The umbilical artery should be between T6 to 9. Same thing you can confirm by ultrasound. So on ultrasound, this is the arch. This is the celiac artery. This is the superior mesenteric artery, and you see the line here. Here, this is the somewhere is the level of the diaphragm, and you can see the line crossing the diaphragm here. Okay. And this is the umbilical venous line. So it has to come from the portal venous complex here. It negotiates through the ductus venosus, and the tip has to lie here between the right atrium and the IVC here. Okay. So you can confirm by ultrasound or you can confirm by doing an X-ray. So I'll just run this video. So after creating the sterile field and taking the informed consent and everything, what we do, we cut it straight, the umbilicus below the clamp. And once you have cut straight, you visualize the vessels. The arteries are the muscular one, the vessels which are muscular. So two arteries in one vein. You have to secure the umbilicus properly and see. So the dilatation of the umbilical artery has started. It's very crucial. So one limb of the forceps is being put. Make sure you don't create a false track. You don't the tissue. So be in the lumen. Make sure you are in the lumen before you start dilating. So you put it. Okay. Now he's trying to attempt. He cannot insert, so he needs to dilate more. So see, so he's doing the tune-up and he dilates that properly. Now it looks to be quite dilated. It looks okay. See the muscular wall. And he takes the umbilical catheter. Make sure you push it inside the lumen, not outside. Otherwise, you'll create a false track. And then for any person, it will be difficult to insert the umbilical artery line again. So here he is. He's inside the lumen. He starts to push. So when you push around 5 centimeters, 6 centimeters, you can withdraw some blood. So push it to the desired distance, and then you can insert the umbilical venous line. I've not shown this, it's very easy. You can fix those, and then you can apply a tegaderm over this umbilical lines to secure it in this position. Some of the units, they make something called the umbilical bridge. Even that is fine, but this is how we do it so that these lines are secured and they can be used. Now, the last one, I'll finish up quickly because I think I have crossed my time, almost 1 hour has passed. The last one is the chest tube insertion. So, this is something which has to be learned because sometimes you are pushed against the wall to evacuate a pneumothorax, or you need to evacuate a pleural fluid because that may compromise the cardiorespiratory system of the infant. So the indication of chest tube insertion broadly is to evacuate air or to evacuate fluid. Now, there are some situations when you start suspecting a pneumothorax. So there's increased work of breathing, there's desaturation, the patient deteriorates on a ventilator, and you are, all have been gone through PALS and NATs where we have told about dope. So in dope, apart from displacement obstruction, pneumothorax should always come into your mind. And you may find sometime asymmetry of the breath sounds. There could be shifting of the midstream or muffling of the heart sounds. And this is an easy way by which you can screen patients for fluid or air. If you do a cold light test, you will find the side where there's pneumothorax. It's brightly translucent. So this is a normal translucency, and this is an abnormal translucency, the entire chest translucence. So there's a possibility of a pneumothorax or a large effusion here. Now, for pleural effusion, there could be certain scenarios, settings which you can suspect. So these are at birth. Some history is present when you're in the delivery room, and there is history of twin transfusion, arrhythmia, infection, some kind of severe fetal anemia like RH setting, genetic syndromes. So these are the settings in the delivery room. Post in the NICU, if someone you can suspect is going to have a fusion after surgery. So after diaphragmatic hernia surgery, cardiac surgery, you can have sometimes chylus effusions. If your central line is misplaced, sometimes you can have a pleural effusion. So this could be settings in the NICUs. So the child starts deteriorating, have respiratory distress, and from birth, if there is high drops or fluid collection, you may suspect that there could be a pleural effusion if your child is not doing well on the ventilator. Now you can again confirm this on ultrasound if you do ultrasounds. So this is a tool again which all of us may we need to learn it in next few years, and this has come up in India in last decade. So this is a normal lung. So this is one space, and you see this lung is moving nicely. You can see a lot of disturbances here. And this lung, if you see, I mean, static here, there's nothing is moving. So here we start suspecting a pneumothorax. And there are some of the other artifacts like A lines, B lines, which we'll not discuss here, but this is how you can compare. This is a normal lung, and this is a lung which has a pneumothorax. And then in a normal lung, when we put something called the M mode, we get something like this, which is called a seashore sign. In a lung which is not moving, if you put the M mode, you get everything straight, which is called the stratosphere sign. So that's how you start suspecting a pneumothorax. And the confirmation is done on ultrasound when you find something called a lung point, which is a combination of stratosphere and the seashore sign. And this is the X-ray where you see a large, huge tension pneumothorax here. For fluid, again on ultrasound, you can see something. The fluid will split the parietal and the visceral pleura, producing a quad sign. And on M mode, you see something called the sinusoid sign. And you can confirm it again doing an X-ray, so that could also be done. Now, for the chest tube insertion, I will quickly take you through the cardinal steps because this is again something important. Make sure you have a written consent. For analgesia here, since it is a very painful procedure, you may need to infiltrate the site with lignocaine and also give some IV analgesia like fentanyl or morphine. Sometimes in emergency situations when written consent is not available, parents are not there in the NICU, you may have to take a telephonic consent. I don't know what is the legal framework, but we recommend our residents to at least record telephonic consent if parents are not available. Now, make sure that before you do it, you may need to sometimes ventilate the baby, take care of the part. It should be done with a sterile technique, monitor the vitals and everything. Usually, you need to put the chest tube around 2 to 3 centimeters in preterm infants and 3 to 4 centimeters in term infant. Make sure that the tube will have some holes into it. So holes should be inside the chest. And you avoid the breast bud. So around that tissue, you should avoid putting the chest tube. Otherwise, the breast development will be hampered. So these are the various the various steps of putting the chest tube, and I'll show you the video so that it becomes more clear. Now, before you're putting a chest tube, just take a brief time out. Just make sure mentally that what side are you going to put it. Make sure don't insert in the wrong side. I mean, that could be a great catastrophe. So confirm the side which you're going to put. Okay. And for pneumothorax, the affected portion needs to be brought little up. So place a roll here or a pad here, abduct the arm so that the axilla is exposed well, infiltrate this area with lignocaine. So the dose is 0.3 ml per kg. And you have to make a sterile field. You need to give IV morphine or fentanyl. The aspiration site is, or the insertion site is crucial. It is between fourth and fifth rib. So the fourth intercostal space, somewhere between the anterior to mid X-ray line, you perform the incision. So between fourth and fifth rib in the mid X-ray line to the anterior, you perform the incision. And you should be targeting the upper border of lower ribs because the lower borders of the upper lip will have the neurovascular bundles. For pneumothorax, you direct the chest tube upwards because air tends to rise up. So you have to direct it upwards and towards the front of the chest. So let your wrist drop down so the tube goes upwards and forward. And if there is a pleural effusion, you direct the chest tube downwards and towards the back. So these are the basic things which you need to keep into mind. Now, these are the steps when you are inserting a chest tube. So this is the standard technique. You perform incision. You take a mosquito forceps. You start separating it, separating the subcutaneous tissues till you hear a popping sound. That means you're in the pleural space. You hold the catheter with the forceps and you insert the catheter with the forceps. And then you take out the forceps and insert the chest tube and you connect it to the connectors. So these are the steps how it is done. Now, this is another method of doing it by a pigtail catheter. It's less invasive. So you put a needle, puncture the pleural cavity, aspirate air or fluid, whatever is there, put a guide wire through the needle. Then you take out the needle and put a dilator to dilate this space. So once you've dilated this, take out the dilator. Then there's a pigtail catheter, which is very soft, which doesn't cause much of injury. You thread the catheter through this guide wire, which is still remaining. And then you take out the guide wire and fix it and connect this with your water seal system. So this is how a pigtail catheter is inserted. This is done in our unit by the intervention radiologists. And if you have time, you can do this. Then how we do it, we use the percutaneous chest tube insertion. And I'll show you the video here. So there are people who have created a sterile field and everything, and they right now they are putting an insertion. They are putting an insertion. Sorry for the size of the video, and they are now taking a stay suture over the insertion. Okay, so they take stay sutures above the insertion and below the insertion. So they keep the threads hanging there because that helps them later to tie the chest tube. And you can do some blood dissection to spread out the space. So here the stay switches are being placed both above and below at the incision sites. So once the stay switches are in place and you have done some blood dissection, that is optional, but you can do it. That's what I do personally to make sure that I don't injure too much when I insert the trocar. So you will take the trocar. So the trocar is to be taken in your dominant hand. Okay? So here you take the trocar and you try to insert the trocar through the incision. Make sure you are in the intercostal space. Okay, so between the fourth and the fifth rib is the fourth intercostal space. You take the trocar exactly at that point. With the other hand, you try to stabilize the other side of the chest. Okay, and then you push the trocar gradually with your dominating hand. Support the other side with the non-dominant hand, and with gentle and gradual pressure, you push it inside till suddenly the resistance gives way and there is popping kind of feeling is there. And you see there, once he has inserted it, already he can see some fluid coming here. And then you gradually withdraw the trocar, insert the chest tube up to the desired distance. It could be 2 to 3 centimeters in preterm babies and 3 to 4 centimeters in term babies. And then what you do, you connect it to the water seal drainage system. Okay, so it's connected. And you make sure if you have done it for pneumothorax, you will see some gush of air, some bubbling happening. Make sure the air column is moving, and then the stay sutures which you have put will help you to tie this. So the stay sutures are already there, and you can tie this around the tube so that it gets fixed up nicely. So it's tied up for one above. So once it goes above the tube, when you go below the tube, just like you tie a braid of a girl, so which we call in Hindi is choti. That's how you tie it, and you need to fix it. Okay. Then you need to dress it and make sure there is not traction on the chest tube. And after this, you need to confirm that on an X-ray that the chest tube is in place. So during chest tube placement, make sure that you monitor the vitals. Your insertion site is very crucial. Avoid the breast bud. Do a chest X-ray later to confirm the position that your chest tube is in place. So make sure that if you put it for pneumothorax, you may get a bubbling inside the chest tube or the condensation. Look for air column movement. And of course, the complications can sometimes be there, like it's incomplete evacuation is something which is very common. This can happen. Sometimes there could be bleeding or there could be injury to the ribs or vital organs, so that could happen. So take care of those complications. And again, documentations become very important. All the cardinal steps needs to be documented. So I think I have finished the what I had already
I think
committed, and
we can take a break, Dr. Anup.
yes,
It's
yeah, we are done.
10:20.
We are done. I'm done, sir. I'm done, sir. So other procedure I'm not discussing because Dr. Pankaj already stopped me and my wife is there already. She's shouting. And this is what happens to married men if they continue doing longer presentations. So thank you, sir. I think I'll finish here and maybe we can discuss this later with questions. And I would like to thank some of my residents who made the video and Dr. Pratima Anand, who provided me with some of the pictures, which is going to be published in a book. And the last message which I would like to give you all is that when you are not able to do any procedure successfully, don't keep on doing it unless you are successful. That's not the right thing. So stop digging and you pass on to some other person like who is maybe skilled, and change of hand might help it out. So thank you, sir. I think I'm done, sir.
Thank you, Dr. Anup. As always, it's a very illustrative session today, and we already spent closer to 1 hour 20 minutes. But procedures do take time, and if you don't explain that in detail, then the benefit is not passed on to the attendees. So before we take the questions, I take comments from
Dr.
Dr.
Anup, please stop sharing the screen. Dr. Anup,
Yes,
please
sir.
stop sharing the screen.
Dr. Ghansham and Dr. Satyan. Yeah, any comments from your side before we take the question? First for Dr. Ghansham.
Yes, sir. It was excellent talk. We learned many things. Those are older. There are revision, and it is much learning for youngers. So what we forget, we revised today about the neonatal procedures. Thank you, sir.
Thank you, Dr. Ghansham, for gracing the occasion. Dr. Satyan, your comments, please.
Yeah, absolutely. These are the basic procedures for all the pediatricians, and I'm really happy to listen to Anup, who's explained it very lucidly. I'm sure there are lots of questions which can be answered by the experts, and it was absolutely a pleasure to listen to this talk.
So let me take the also to welcome Dr. Ravi Sachan. Dr. Ravi Sachan is Professor Neonatology at UCMS Hospital, and he is a co-host for today's session. And I request Dr. Ravi Sachan to many of the questions he has already answered, but yes, some of the pertinent questions we can take up now. Dr. Ravi, over to you.
Thank you, Dr. Pankaj. And I think Dr. Anup has already, explained in a very, comprehensively, covered very comprehensively. So let's take a few questions. Dr. Anup, I hope and thank you for your nice presentation.
Nice to see you, Ravi. I think you are still in the Sunday mode right now.
Yes, yes, of course.
Welcome, Ravi. Welcome.
Dr. Anup, there are a few questions regarding surfactant. So let me discuss one by one. So first of all, there is a question. There are the different brands are available in our market. Is there any efficacy in your final words about for the
Uh,
surfactant available?
Yeah, so if you look at head-to-head trial with the similar dose, 100 milligram per kg, there's no difference. So whether you use Curosurf, you use Serventa, you use NeoSurf, whatever you're using, that's fine. But what studies have found out is that 200 milligram per kg of protectant, which is Curosurf, is superior to 100 milligram per kg of Serventa or Curosurf. So if you go higher dose, 200 milligram per kg dose of Curosurf, it is found to be superior to 100 milligram per kg of other surfactant plants. So, but 200 milligram per kg of Curosurf has not been compared with 200 milligram per kg of Serventa or the surfactant. So that is
Okay.
what most interested. But again, cost becomes an issue. So cost really goes up.
Yes, of course, of course. Because it protected alpha is the quantity is more and which is very costly.
Yes, it's
So
costly.
another question is one is asked by some Dr. Aspreet. So she said after giving installation of surfactant, is there any mandatory for the X-ray, or if it is there, then how many hours of the installing the surfactant X-ray should be done?
Yeah. So X-ray is not mandatory for giving surfactant or for extubating the baby. It's not mandatory. So if because sometimes you need to give surfactant much early, maybe in 15 minutes, 10 minutes, 5 minutes. So you'll not wait for the X-ray. So premature babies, once you intubate, and it depends how your setting is. Some people prefer to give delivery room surfactant. Some people prefer to give surfactant as soon as the admission has been done, whatever is the process. So don't need to wait for the X-ray to give surfactant. And if you're doing ensure, for example, you're given surfactant and you want to extubate the baby, again, you don't need to wait for the X-ray. So you might extubate the baby. And
So
then once
baby,
you've extubated the baby on CPAP, then you can keep on doing whatever is the standard protocol. You have to do X-ray, you want to document, that's fine. But for giving or extubating, you don't need an X-ray.
okay, okay. And Dr. Anup, is there any criteria or timings for the repeat surfactant if at all required? Repeat dose of surfactant.
Yeah. So again, repeat surfactant, if you look at the European recommendation, is that if your settings are similar to what were previous, like a PEEP of 6 centimeter, MAP is 6 centimeter, FI2 is at least 30%. So FI2 30% is taken as a cutoff. Some units take 40% as a cutoff. That is one thing. So for repeat dose, when to repeat if your settings are again going high, if the child had initial some response to surfactant, and the third thing is that you need to see at what duration you're going to give the repeat dose. So for Serventa, for example, as per the manufacturer's recommendation, you can repeat after 6 hours. For Curacao, you repeat after 12 hours. So it can lead the leaflet because each brand and type will have a different kind of recommendation. Serventa is 6 hours, Curacao is 12 hours, and then NeoSurf had not written that when you need to repeat. So we take it roughly between 8 to 12 hours. So you need to repeat it. If your FI2s are again going up, there is a setting of prematurity, and you have at least done one X-ray to document that there is no pneumothorax, there is no other kind of lung pathology there. So before repeat dose, I would recommend that you make sure you have at least one X-ray.
Okay, okay, fine, fine. And of course, these are the mere recommendation, and other clinical parameters also decide about the repeat dose of surfactants.
Yes, yes.
Dr. Anup, one question from Dr. Arvind. Is there any role of surfactant for meconium aspiration, MAS, what we call?
Yeah, so if you look at the extended benefits of surfactant, there is a role of surfactant in MAS. So babies who have hypoxic respiratory failure, who have a setting of meconium, may benefit from surfactant. It cut down the need for ECMO by 40%. So roughly, if you want to take which one to give, should we give to all? No, not to all. So if baby has history of meconium aspiration and baby is on higher settings, say a MAP of around 12 and FI2 40, 50%, that those are the babies who are going to land up with hypoxic respiratory failure. In those patients, you can consider giving a dose of surfactant.
Okay, thank you. Dr. Anu, one more question from Dr. Arvind is there any benefit of giving different types of comparing different types of procedure between the LISA and what we call the different modes is available now. MIST is also. Is there any difference of and which if it is practice, then which would be better than giving invasive surfactant?
So basically, this was a presentation for a basic office-based pediatrician. So I just covered up giving surfactant through endotracheal tube, which is the most popular way to give surfactant, and that is has remained the standard of care for many years now. Since 2009, 10, the first study of called MIST, it has different acronyms. So it's called lesser invasive surfactant therapy. There are many other names which have come up, like the Howard method and so on. So these were for babies who are spontaneously breathing, they're on CPAP, and you put a thin catheter. So you put a thin catheter and you deliver surfactant in babies who are breathing spontaneously through a thin catheter, which passes beyond the vocal cords. So this is called LISA or MIST, and people have tried with different kind of catheters, umbilical catheter, and now you even have tubes which come up, which are manufactured by some of the companies, which are very thin, and LISA or MIST could be done. Now, if you look at the evidence in last 15 years, so LISA and or MIST has very strong evidence to be beneficial compared to ensure and compared to all other methods of surfactant administration in terms of decreasing the need for ventilation, decreasing bronchopulmonary dysplasia. And I think right now there are more than 20 randomized controlled trials which show that LISA is better. But again, LISA is something which has to be learned. It's technically much more demanding. It's like a package. It's not just putting the catheter. It's like a package which you need to learn for asepsis, caffeine administration, what kind of sedation you need to give, analgesia and everything. And a good LISA, a good ensure is better than a bad LISA. That is what we tell everyone. So if you're doing ensure, you're good in ensure, and you don't know how to do LISA, don't jump into LISA because it has shown evidence. So LISA has a package. It has to be learned. So there are LISA trainings which are done abroad and in various workshops. So before you just jump to LISA, you make sure that you are trained, you have done LISA in mannequins, you have learned it, and then you may gradually shift to LISA if you're confident and if you have that 24/7 support. You are training LISA, but you are not there 24/7. So does everyone in the unit learn LISA? So that's also important.
So I think Dr. Anu message is very clear that means in which unit you're is comfortable. I think your nursing staff and your doctors and residents,
Yes.
the unit is comfortable of unit is as far as procedure is concerned is important. Okay,
Training
thank
is
you.
very
So one more question regarding peripheral insertion of IV cannula. The Dr. Megha is asking, is the analgesia is must for all?
Yeah, so this is something which we are not tuned to because even the college where I worked in, I was not tuned to newborns having pain. So they also have pain. There's pain scoring system, everything is done. And for every like procedure, whether it is even an IV cannula, whether it is even doing a blood sugar, you should take care of the pain part. Just imagine someone is putting a cannula in you. Do you feel pain? You feel, right? And think about a newborn baby. I mean, the newborn baby also feels pain, and you need to take care of the pain part. So, if you don't have time to apply Emla cream or apply lignocaine gel, at least you give some sucrose to the baby, or you can just tuckle the baby or hold the baby closely, tightly. Even these non-pharmacological methods also decrease the pain. So, any procedure, you have to take care of the pain part. You have to engrave this in your culture. So I am not saying that 100% of my babies, they get analgesia when they put IV cannula, but this is something which is recommended and standard, and we have to move towards it.
Okay, Dr. Anup, one question regarding the performing the CSF analysis or lumbar puncture. What is the minimum requirement of platelet should be there, or if it is there, then what should be the level?
Okay, so again, basically bleeding is a contraindication for doing a lumbar puncture. And when newborns come to us from outside, outborn newborns, when they come to us, we don't even have their platelets when we actually do a lumbar puncture. So if you're doing it as a platelet, then of course beyond 50,000 is always safe to perform. But routinely, if the child is not bleeding, then you don't have a contraindication to perform lumbar puncture. You don't need to document a CBC always before doing a lumbar puncture. If your baby is not having bleeding from puncture sites, having not a OG bleeding or hematuria, you can perform a lumbar puncture. Make sure the baby is hemodynamically stable, is not having hypotension, which is refractory, or is having a high ventilation requirement and still desaturating, then you may avoid it. Otherwise, platelet count per se, we don't document before doing a lumbar puncture.
So, Dr. Anup, the question is being very specifically, what is the minimum level of platelet count if it is odd? We know that above the 50,000 will be comfortable. So, is there any minimum cutoff for the
So what I'm telling you is that there's no cutoff, and we don't document a platelet count. If the child is
Okay.
not bleeding, it is fine. You can go ahead and
Okay.
perform it.
Okay. So, if one more question related to the lumbar puncture also, if it is a traumatic trap and want to do the next, whether to remove the needle or not, I think yes, of course, if it is a traumatic, we have to remove the needle and wait for next 48 hours. Is it okay, Dr. Anu?
Yeah,
Any?
so if you have inserted the needle in the L4, L5 space, and when you insert the needle, if there's some blood has come up, so you can wait for some time and let the blood to clear. Maybe sometimes what happens, the blood clear can correct the sample which comes later on. That is one thing. But if it's still purely bloody, that means you have hit a blood vessel, then you leave that. Insert another needle one space up. And even if that is traumatic, then as Dr. Ravi had said, that you abandon the lumbar, you do it after 24 to 48 hours.
Again, this is related with the LP also. Whether we require a routine sedation or some non-pharmacological measures would be enough for
No,
this.
analgesia is fine. We don't need to sedate, because if you sedate babies who are in room air, they can have apnea. Don't sedate it. But yes, you can give sucrose. That is one thing. And uh, the EMLA cream is very good. It can be used in babies who are more than 32 weeks. Then we have LPs are planned. You don't do it suddenly. It's not emergency. So those cream needs to be applied before 30 minutes. These are available. Only thing is our kind of mind block not to use it, because we're not tuned to pain. So in fact, we used EMLA cream in one of our studies, and we found that it decreases the PIP score, and it also decreases the dry taps which you have in traumatic taps. So something which can be engulfed into our day-to-day practice.
Okay, if the pharmacological agent is available like IMDA, it is okay. Otherwise,
Yeah,
non-pharmacological measure, express
suckling,
breastfeeding
this is
or
fine. So
cuddling
yeah,
can be
yeah,
tried.
yeah, yeah.
Okay.
Creams are
So,
available now routinely, and they are not expensive. They can be used.
okay. So one more question in the chat box is before inserting the PICC and whether we require a routine, for heparinized fluid to be, given for priming.
No, we don't need to prime the PICC with any heparinized fluid. Okay, so uh, whatever line you are inserting, whether it is PICC, whether it is umbilical artery, whether it is vein, you just need normal line to flush the line and take out the air. You don't need to heparinize any.
Or it is required for to maintain a patency of fluid,
Yeah, so if you put the line and if there's nothing is running, for example, you have kept the line just for antibiotics or antifungal, which is to be given for 4 to 6 weeks, then you need to run the heparin solution through the line.
Okay. So for to make a patency of the,
To maintain the
in the
patency, if
time,
there's you need the
we
heparin
require
solution.
heparinized fluid. So next question is for how many days, we can keep the PICC as well as for UAC, if at all, and what all the medication which, which are contraindicated, or there can be some medication which are, the terminal site incompatibility. So just please throw some light on these issues.
Okay, so if you look at the recommendations, umbilical artery and umbilical vein, the recommendation has to be kept maximum for 5 days, and umbilical vein maximum for 14 days. Now the recommendation have changed, and the maximum duration for which you can keep a UA and UV is now 7 days. That is the recommendation by the CDC. Now, but the idea should always be that remove the line as soon as possible. So if it's not required, remove it. You do not wait for 7 days, kind of stuff. So remove the line as soon as possible. Otherwise, it's a needed for infection, thrombosis, and complication. For the PICC line, you have to follow the manufacturer's recommendations. So most of the lines which come through Vigon, I think the maximum duration recommended is around 27 or 28 days. That is what is recommended for PICC lines. So these recommendations are there online. You can go to the site. So PIC line around 27, 28 days, roughly, I think it's 4 weeks. And UAUV maximum is 7 days. But is very strongly that you need to remove the line as soon as possible. That is not required. That should be asked every day in the unit.
Exactly. So any medication about Dr. Anup which can be given or which are absolutely contraindicated or which can be terminal site compatibility?
Yeah.
Any your suggestions?
So first of all, if your umbilical venous line, when we talk, you should avoid giving bicarb through UV line, because if it's strongly placed, it's very hyperosmolar. It can cause hepatic necrosis also. You cannot transfuse through a PICC line, either platelets or PAC cells, so it will block the line, and that should not be used. So osmolality from 900 to almost 1800 hyperosmolar fluids are compatible when you are using a PICC line, so that should not be a problem. When you are giving IV fluids, then you should not use the same line to give calcium and bicarb both. So that should not be compatible. So don't in bicarb. So if your child needs bicarbonate also and calcium or also, then you have to take another line to infuse the other fluid. So that needs to be taken care of.
So can alone calcium
Alone can be given. Alone can be given. Yeah, alone can be given.
Okay. And through
Yes.
Okay. Thank you. And one more question come up with us regarding the surfactant. So he's saying about when asked by the anonymous attendee. So he's saying for after how many hours of giving surfactant we can suction out, or
Okay,
is
so
it routinely recommended?
yeah. So there are recommendations. So for 1 hour, that is recommended. If you read all the manufacturer's leaflet, whether it is Saventa, Curosub, Neosub, if you read the leaflet carefully, and if you go to standard sites also, they say that for 1 hour at least, you should avoid doing suction if the endotracheal tube is in place. So unless like you're pushed against the wall, child is desaturating, you are not able to manage with FI2 and increasing tape, there's complete obstruction of the tube, you should avoid suction for 1 hour. That is what's recommended.
Okay, Dr. Anup, I think you have already covered all these topic, but again the question is there. So where to keep the tip of the PICC in as far as X-ray is concerned?
So the tip of the PICC line, if you're putting in the upper limb, the ideal position is between the superior vena cava and the right atrium junction. Okay, that is where we want it to be. It should not be intracardiac. It's not acceptable, right? So that will correspond on X-ray. So below the carina, between say 1 to 1.5 vertebral units. So if you can see the bifurcation, that is the carina, and from the carina, one vertebra and the disc is 1 unit. So at least 1.2 to 1.3, which means say roughly 1.5 vertebra and disc. If you're below the carina, that is accepted.
Okay. So Dr.
And for the
Anup,
lower limb, it should be between the IVC and RA junction. So if it is near the right dome of the diaphragm, that is fine.
Dr. Anup, one more question regarding the low-lying UVC. So what are the complications are associated with low-lying UVC?
So low-lying UVC is not acceptable. You need to pull out the low-lying UVC. You need to pull out the UVC which is curving, which is bent, whatever. So that is not acceptable. Now, unless like for maybe for 24 hours, your patient is very sick, you need to give anotropes, that's fine, but you need to take that out. So a low-lying UVC can cause a lot of complications. One is that you cannot give any hyperosmolar fluids through it. It can cause hepatic necrosis. It can cause portal venous thrombosis, which can later lead to hypertension. It could be a needus for infection also, cause liver abscess also. So a low-lying UVC is not acceptable, and you should not be compliant, or you should not accept any low-lying UVC just because it's something that you're able to give some product. So that's not acceptable.
Okay, okay. So there are not many complications for low-lying UVC.
Low-lying UVC is.
And another question is, suppose a newborn baby comes in outborn nursery whose the cord, umbilical cord has fallen. So still, is there any, possibility of giving UVC, putting a UVC line?
Now, again, this is something which we do because we have passed out from colleges where we have this kind of scenarios. So sometimes this can happen that there is no cord, and patient has come to you, example, day 6, day 7, day 8. So even in these cases, we expose the umbilicus. We clean the umbilicus with normal saline. We try to make it wet, and we try to explore and see if there is any opening of the UVC. Sometimes we are able to find some opening, and we try it as a blind process and it goes. But if the cord is not there, it can be difficult. And more are the postnatal days, it's much more difficult then.
Yeah. Okay. So I think this has already been covered. And what is the size of chest intercostal chest tube insertion in unit? It's talking about the pneumothorax drainage cannula. What are the different
So
sizes available?
you have 8 size, 10 size, and 12 size, which is available. 8 size can be for babies who are less than 1.5 kilos. So 10 could be between 1.5 to 2.5 kilos, and more than 2.5, 3 kilos, you insert the 12 size. So usually we use the 8 and the 10 sizes most commonly, the trocas which we have chest tube.
And one more question is regarding the change in position while giving surfactant. Is this really recommended or?
No, that's not recommended. That was what people used to do initially when surfactant came to India, and that was a recommendation by the manufacturer also. You give one liquid, then you turn upside like this, left, right, and all those. So those recommendations are no longer there. You just need to access the endotracheal tube, and you give surfactant in 3 to 4 liquids. And don't need to change position. Give it as soon as you can, as long the baby is able to tolerate it.
Okay, and how UVC can causes cardiac tamponade or pericardiac hemorrhage?
Yeah, so
Okay.
if the
Dr.
umbilical
Hardik
vein
is
is,
calling.
yeah. So if the umbilical venous cannula is deep, or even if PIC line, PIC's line is deep, so if it's in the RA, then it can cause arrhythmia because the SA node is near that. So it can lead to arrhythmias, it can lead to supraventricular tachycardia. So that can happen. And these lines, they can pierce the endocardium, and they can cause effusions and tamponade and hemorrhages. So intracardiac line could be dangerous. They can even cause thrombus. A huge cardiac thrombus also can be there. So a line which is intracardiac is again not accepted.
And one last question by Dr. Pooja Sarma, sir. What should be the dose of heparin to be infused?
Again, heparin dose, it comes in 1000, I think, IU per ml, and you need to go into multiple dilutions. So you withdraw just 1 ml, dilute into 10 ml, again take 1 ml of that, dilute into 10 ml. 3 times you can do that. So I will share that with Pooja.
Okay, okay. So I think there are a few questions which has already been covered by the our expert. And one, I think 3 or 4 requests is being for the organizers. They are requesting for these presentation to be shared among the colleagues, and along with the videos they are demanding. So whatever you have shown, can it be shared with our audience so that it can be multiplied. So I think all the question answer has been covered, and it has been very comprehensively, lucidly explained by the Dr. Anup. Thank you so much. And now over to Dr. Pankaj and rest of the organizer. Thank you.
Thank you, Dr.
Thank
Ravi.
you.
And definitely, I think this presentation will be uploaded onto the platform. So you can listen to the presentation again. I'm sure that will benefit all of us. But I think what important is that still we request all the delegates to be online, because then it is more interesting and interactive for the speaker also, and then the question answer can also be better answered. So with that, I think we are already 1 hour 50 minutes. They were maximum participants were around 350, and we had closer to 70 questions. So I think Dr. Anup has been very patiently answering all the questions to the fullest satisfaction of all the delegates. So this, if there is nothing else, we'll thank Dr. Ghanshyam Chaudhary, CIP EB member from UP, and Dr. Satyan Hemizani, our neonatologist from Fortis Hospital, Jaipur, Dr. Ravi Sachand, our professor at UCMS. I can see Dr. Sanjeev Kumar has also joined. Welcome, Dr. Sanjeev. And I can see Dr. Ajay Gupta, Dr. Alok Bhandari. Everybody has been keenly listening to this talk. Thank you so much. And don't forget, next Sunday is again an interesting session. And that is none other than myself. I will be discussing some of the interesting neonatal X-rays next. So keep you online, because then it's more interesting for me, because it is going to be more interactive. I'll be posting X-ray, waiting for a second, and then see whether you can answer that in the chat. So with these words, thank you IIP Delhi for giving us this platform, and have a nice Sunday. Enjoy yourself. Bye-bye.
Thank you.
Thank you,
Have a nice day.
chairpersons.
Thank you, Pankaj sir.
Thank you.
Thank you.